Hi, Frontline Teach, it's Val Soul. I'm back to talk about HIV treatment decisions and guidelines. And this piece of the curriculum is really about the decisions that people make about HIV treatment. A fundamental thing to understand, particularly for those people not living with HIV, helping other people who are living with HIV make decisions about treatments can be really difficult because the treatments themselves are hard to make. Whether someone is starting treatment or staying on treatment, having to change it, or just feeling over it, or if someone's starting to run out of options, the treatment decision making is more complicated than just a binary switch of be on it or don't be on it. A lot of factors go into the treatment decision. Fundamentally, we want to know how is someone's health, not just how is someone's CD4, how is someone's viral load, but what's the health like, what's their overall immune system like, do they have other health issues that they're going through like diabetes. We are interested in knowing, or we should at least be checking for, we're probably interested in knowing the factors about people's lives that would go into or influence treatment. Where someone is living, if they're, in a program, if they're in a halfway house, if they're working, if they're raising kids, and what disclosure decisions they've made to those kids, for instance. We are interested in assessing side effects and disclosure, like I mentioned. I kind of jumped the gun a little bit, but just having HIV meds on you is disclosing if somebody were to find those meds. So it is actually, there are impacts for disclosure decisions here. Fundamentally, we believe that if it's your treatment, it should be your decision whether or not to be on it. Treatment should be based on what will work best for you. And we believe this to be true both for HIV negative adults and HIV positive adults. Some people are interested in treating aggressively. That is, like, every malady that they have, they want a pill for. Every diagnosis that they get, they want to treat it to the nth degree. Some people aren't there. Some people don't want to treat aggressively. One of the important lessons to pass on for Frontline is that I want to give you the big picture of the treatment decisions. But fundamentally, each individual person is going to know best what works for them. What side effects can your body handle best? Some people are fine with a little bit of nausea, but they hate diarrhea. Some people, diarrhea doesn't bother them, but if this gives me a headache, I can't take it. So knowing your own body is going to help you to understand what side effects are best. Fundamentally, only you can decide for you. At the end of this presentation, we've got long lists of questions. We're not going to go through them exhaustively, but they can really help. They can be good prompts for helping someone to determine their goals for treatment. I do want to mention everybody who is living with HIV should be seeing an HIV specialist. And HIV specialists see a lot of people with HIV, that is more than 50 people with HIV in their practice, and follow updates and treatment information. Would you go to an eye doctor for a toothache? Gosh, I hope not. So if you're not sure if your provider is an HIV specialist, or if you're not sure that somebody that you're working with is seeing an HIV specialist, we can help you find out. There are a couple of databases that we can use. So all treatment has benefits and risks. Antiviral therapy, that is the meds that are used to treat HIV, has benefits and it has risks. So some of the benefits of HIV treatment might be to reduce viral load, protect and bring back immune function, or hold off or get rid of HIV-related illness. But all of the meds also have risks. They have side effects, both short-term and long-term side effects, and there's a risk of developing drug-resistant HIV, which may limit someone's treatment options. In fact, the number one risk for developing drug-resistant HIV is being on meds. So we're not going to say, don't take meds because the risk of developing resistance is too high. But it's important to be aware that that is actually a risk of treatment, and someone can run out of options very quickly if they are on treatment but don't want to be, aren't bought into it, and aren't taking it the way that it's prescribed. So each individual drug also has benefits and risks. So this is an old example, Viracept. It's not used very often anymore, but this, I sort of keep the historic pieces when I can of the TEACH curriculum. So for example, Viracept, it's really working for me. This was a person's real example. My CD4s have gone up and my viral load is staying down, but the diarrhea from it drives me crazy. So this person, the benefit of Viracept for this person was exactly what we wanted to see. But for them, I don't think that they came to the conclusion that this risk was too high. I think they decided they could live with it, but it was a downside. Again, it's not just a binary switch, be on meds or don't be on them. If you're on them, there are costs, there are risks. So there's also I want to acknowledge that we don't know everything. We don't necessarily know what is the best HIV combo to start with or switch to. I'll show you where there are guidelines, recommendations for what to start with, but we don't definitively know, and we definitely don't know in terms of, say for instance, an individual person's side effect, like sweet in their body, like how their body reacts with meds. So the point is, some people trust their providers to make those decisions. Others do research to propose new regimens that they want to try. This is a place where the AIDS library can definitely come into play. 215-985-4851 is the number for the AIDS library, and that's a great place where people can learn about individual medications or regimens. But we don't know everything, but we do have guidelines. The HIV Treatment Guidelines were first written in 1997 by a group of HIV docs and community activists. It was actually the ACT UP Philadelphia Standard of Care, was the first standard of care for HIV that was ever written. It was essentially adopted by the feds because it was so good. And so these guidelines are revised when they need to be to reflect new meds and new understanding of old meds. The most recent revision to the adult ARV guidelines, again, adult antiretroviral treatment guidelines, was February 2013. And it's a living document, which means that revisions happen on the web. The guidelines are always available, and they always highlight what's new from the last edition. So this is a picture of aidsinfo.nih.gov, and this is what we're talking about, the guidelines. There are guidelines for the use of pediatric antiretrovirals, overall guidelines to reduce the chance of perinatal transmission, and guidelines about treating and preventing opportunistic infections as well. You can also see on AIDS Info, there's all sorts of stuff. There's sort of news, you can get the page in Spanish, there's corrections, there's a lot of info on the drugs themselves, although it's very much written for researchers and medical providers at that level, and not so much for the people. So who uses the guidelines? Well, they're particularly useful to providers who don't see a lot of people living with HIV. When a provider starts to see a lot of people with HIV, again, the HIV specialist who has 50 plus people in their practice, that provider is going to be a lot more adept at figuring out what to start with than somebody who, out of a practice of 75 people, only has one person living with HIV. So HIV positive people, treatment educators, and activists can use them too to both see where we stand individually and look for sort of points to promote. It's important to say they're not a one-size-fits-all formula for treatment. You're not going to look into the guidelines and see, okay, so I-Valsol should be on Sestiva, because they're not written for me. They're written for the provider to help them figure out what to do if they've got someone who's HIV positive in front of them. What's the standard of care? What's the best possible treatment? So we like to say at Project Teach, they're tools, not rules. There may be people who are on regimens that aren't recommended in the guidelines. There may be people who delay treatment far past what the guidelines would recommend. These are tools for us to use, not rules for us to live by. So, from the guidelines, the goals of HIV treatment are, first one, and I have to say, I'm going to put all of these up. In my years of doing this presentation, these 4 goals have swung back and forth. They've switched places a zillion times. This is our current best assessment of what the goals of HIV treatment are. So, reduce HIV-related illnesses and death, and improve quality and length of life. Well, that's plenty. That's a really big one, and it covers a lot of ground. But the second goal of treatment is to bring back immune function. Number 3, to keep viral load down. And number 4, actually, to prevent HIV transmission. And we do know that the more effectively someone's viral load is treated by being on meds, and the more likely pretty tired, folks. Sorry. The lower someone's viral load is, the less likely they are to treat HIV. Believe it or not, we didn't always know that. And it's been one of the sort of growing pieces of the last couple of years to keep that information out and about and on people's minds, that actually treatment reduces the risk of HIV transmission if people are on it and it's working for them. So people might have different goals than this. People might have benefit that a benefit that they're looking for that is not necessarily on that list. Maybe the benefit that they're looking for is to gain back some weight or to start feeling better. That would, I guess, fall under quality of life, but people might not put it in those terms. It's important to recognize that people are coming into this not as vacuums that just line up with what the guidelines say, but as actual humans who may have opinions that are different than what the guidelines say. So this is what the guidelines say about who should be on treatment. At any CD4 count, at any viral load, if someone is positive, the recommendation is that they start treatment. It used to be that it was like, if your CD4 count is below 250, then definitely start, but if above, then you can maybe wait. But the guidelines are really clear now. Everybody should be on treatment. Now, they have kept a bit of that structure in terms of the strength of the recommendation. An A1 recommendation from the guidelines is absolutely a very strong recommendation. So our very strong recommendation is if your CD4 count is below 350, if you're pregnant or have any history of an opportunistic infection. Very strong recommendation to start treatment. There's a strong recommendation, not very strong, just strong recommendations to start treatment for CD4 counts between 350 and 500, or if someone has kidney disease or hepatitis B co-infection. And then there's a moderate recommendation to start meds if the CD4 count is higher than 500. So they've maintained a little bit of the wiftiness of like, oh, if X, then Y. But really, this is what you need to know. The recommendation currently is everyone should start treatment. It's also recommended because it does prevent transmission of HIV. The strength and evidence for that recommendation also varies. For perinatal transmission, that is transmission around the time of birth, it's a very strong recommendation, and that's been part of the guidelines for avoiding perinatal transmission for a long time. For heterosexual transmission, it's also a very strong recommendation. For other transmission risk groups, it's a less strong recommendation, not because it doesn't work, but because the research isn't there to back it up. And this document is very much based on what does the research say. So the bottom line here says, the guidelines say everyone who is HIV positive should be on medication. But this is what we say, you shouldn't start until you're ready. If you start before you're ready, you may not get the benefit that is expected, because you probably aren't going to be bought into taking them. So this is the actual language that it's written in, and what I just said. Patients starting ART should be willing and able to commit to treatment and understand the benefits and risks of therapy and the importance of adherence. Patients may choose to postpone therapy, and providers on a case-by-case basis may elect to defer therapy on the basis of clinical and or psychosocial factors. The whole thing is written like that. It's very dry, not great reading, but this is really important because this is saying that, like, yes, we want everyone to be on treatment, but actually maybe if you don't have a house and a place to store meds, then maybe it's more important to get that stabilized so that you can really commit to the meds. Just as one example. So the guidelines also say they weigh in on what to start with. And there are so many combinations of meds to choose from. We have over 30 meds that have been approved for the treatment of HIV. So every doctor on the case, every medical provider who prescribes HIV meds are going to have their own sort of sense of what works best. But what the guidelines say is that they recommend basically Sestiva, tenofovir, and Emtreva as the strongest recommendation. And then there are all of the meds in these 4 bullet points carry an A1 recommendation as being very strong. Now, this is not the place for me to tell you about all of these meds. You should know that what we're looking at here are the generic names. What I just said are the brand names. And then what this is actually the research name. So every HIV med has 3 names. It's very confusing. And so if you need information about a particular med, I would encourage you to reach out to me so I can get you good sources for readable information, because a lot of stuff about meds is not readable. So do not panic. I love to see that. If you're on HIV meds or you're working with someone on HIV meds and they're not on one of those recommended combos, do not panic. It's okay. There are a lot of combinations to choose from and many things that can affect your options. So some of these considerations would be other conditions: hepatitis, TB, depression, mental health, cardiovascular disease, chemical dependency, pregnancy. All of those can impact what is the ideal combination for a person. Adherence potential. How likely is someone to take the meds as prescribed? That can change what the preferred combo is. Dosing convenience, potential for side effects, potential drug interactions with other meds, potential or planning for pregnancy. All of those play a part. So this, I'm just going to breeze through. All of these are questions that we recommend people ask. Maybe not all of them all at once, but we recommend that people do take into consideration more than just, did your doctor say it? But is your doctor trustworthy? How are you feeling? Do you need a second opinion? Did you get a second opinion? How high is your viral load? What questions will you ask? How does this meet your goals? More questions, lifestyle considerations. Some of these are a little bit, like, do you have a working fridge? Well, we don't have many meds that have to be refrigerated anymore, but this used to be actually really serious, where like if there were certain meds that if somebody didn't have a fridge to put their meds in, we couldn't prescribe them meds at all. A lot of the ones at this point in the epidemic, they've heat stabilized formulas now, and so this is less of an issue. But that's here in the US, and that's not necessarily true everywhere around the world. So other questions, I cannot read each one of these off to you. I'm looking for this slide. It should be clear to you that antiretroviral treatment is a commitment. When someone undertakes this commitment, it's big and there's a lot of pieces to it. Not everyone has to be on treatment, but everyone has a right to it. Everyone should be able to access it. Someone who chooses not to be on meds should still continue to see their provider, just to keep the lab work, keep checking the lab work, to treat symptoms, to make sure that their health is in okay shape, even if they choose not to be on meds. I want to recommend that people ask for and share new information, particularly as new meds come out. Anecdotal evidence has always been important in this epidemic, and that is, anecdotal evidence is what some people might call stories or gossip, and it's one of the primary ways that we share information as humans. It's also told us very important things about the treatment of HIV. And the recommendation is not to compare yourself with another person's experience with HIV treatment, that people don't respond all the same. Preparing for treatment changes take some work, and I guess that's the end of my slideshow. I'm relieved. That was a lot. Thanks for sticking with me. And I'll talk to you later.